I'm Kathleen Shannon-Dorsey, and I'm here now to welcome our Dr. David Maloney, who is coming forward. This time he is going to be talking about the medical perspectives of cellular therapy, and he's coming to the stage here, so let's welcome David.
Okay, so back for round two. So this is going to be a little more of the medical perspectives of cellular immunotherapy and maybe where the field's going a little bit and the lessons we've learned in our dealings with patients, predominantly with lymphoma. I'm really going to focus on lymphoma because that's where we have the bulk of our data. If somebody could push the timer start button, that'd be great, so I know when I'm out of time. Great. Out of time already, so sorry. No. Okay, so these are my disclosures for this. I receive research funding from Geno therapeutics and Cellular, and I give advice to anyone who will listen, and sometimes people who won't listen in the CAR T-cell field, including Geno, Roche, Genentech, Kite, Gilead, and Novartis. All right, so why are we all so excited about this field? And T-cells are really amazing pieces of machinery. They can recognize abnormal cells based on the peptides that are presented in class 2 molecules and our class 1 molecules, and these T-cell receptors are specific for a small peptide that can be distinguished between a normal protein and an abnormal protein. And T-cells are incredibly specific. That's what cures you when you get the flu or when you get viruses, and it also patrols against cancer. The problem is they're like 1 in a billion because there's billions of types of T-cells, and to try to find one that is specific for the T-cells has been very difficult to expand. So how can we do this better than just relying on your normal T-cells to attack your cancer? So there's been really two approaches, general approaches. The first one is shown on the bottom of the slide, and that's tumor-infiltrating lymphocytes. So the observation was made if you take a tumor out and grind it up and isolate the T-cells from there, some of those T-cells are actually in there trying to kill the tumor. And if you take those T-cells and then grow them in the lab and expand them to a much higher level, give them back to the patient, usually with IL-2, it takes a few months to do this. You can grow up a few billion cells and give them back. Most of them aren't reactive with the tumor, but some of them will be, and this can cause complete remissions in some patients. And so the tumors that this works in are tumors that are really screwed up, like a melanoma, cells that really have a lot of genetic abnormalities. But this is actually a curative therapy with people with widespread metastatic melanoma and a few other cancers. And there was big hot news, and I think came out in the last couple of weeks about, I think it was I can't remember the cancer, but it was a case of a TIL that they actually dissected down and figured out the T-cell that was actually capable of rejecting the tumor and then expanded that. And so there's going to probably be still a future in this, but right now it's complicated. So the second way around this is you say, we don't care what the T-cells are against, we're going to just modify them to attack the cancer. And there's two ways of doing that. The top of this is the T-cell receptor transduced cells, and that's where you actually put in a T-cell receptor for that, whatever the target is. And then the bottom one, obviously, what all the action we're talking about is the CAR T-cell field, where you actually modify the T-cell with a CAR, and that has some advantages. And so let's look at those just real quickly. So what's the difference between a T-cell receptor treatment versus a CAR genetically modified cell? So the T-cell receptor is again, that's the native T-cell receptor, but now you clone it out against a tumor-specific antigen. It's really potent. It recognizes internal cells, abnormal proteins in the tumor cell. It can respond to extremely low density, but it's restricted to the HLA type. So what does that mean? So that means if you're going to make a T-cell receptor, you would have to make a T-cell receptor for every HLA type, or else you would have to restrict this to patients with HLA-A2 and the right T-cell receptor, because the T-cell receptor binds to the class 1 or 2 molecule and the peptide. So you can't just pull out one receptor and use it in everybody. So it's much more complicated, and depending on your diversity of HLA type, you then have to find peptides that work in each setting, and it's complicated. But if you can find those abnormal peptides and a good T-cell receptor, this can be incredibly potent. And I think it will be the future because it's incredibly specific. So the CAR, remember, the CAR is different. The CAR is an antibody stuck on a T-cell receptor, and that antibody basically then redirects the T-cell to an external antigen on the cell surface, so a target that's on the cell surface. And this is no longer HLA restricted, so you can go into anybody's HLA type, and one CAR should work in every patient in terms of that target. It responds to surface molecules, so you can't target something inside the cell, and it requires relatively high density, although that's somewhat debated. It's not HLA restricted, and it's potentially more widespread. All right, so that's why we're going to talk about this one. All right, so this is what the T-cell receptor looks like. If you're going to do that transfer, you have to put in external T-cell receptor. The problems are it can pair with the internal the endogenous T-cell receptor, and that gives you a bunch of mixed molecules that don't function, and so it's a problem. But you can, if you do it right, attack many different types of cancer. And we have several clinical trials at WT1 and AML and some other cancers with T-cell receptor modified cells. Now, what's got everybody jazzed about is the chimeric antigen receptor transfer, the CARs, and this shows the 3 current versions of the CARs. The shown on the far left is the CARs that are first generation, and this was just basically sticking a combining region of an antibody called a single chain FV onto the internal portion of a T-cell receptor, and it actually didn't work very well. And so this was done 30 years ago, but it didn't really work. The breakthrough is shown in the middle, and that's called the second generation CARs, and the difference here is they put a second signal attached to this molecule. So now it's an antibody, the internal portion of a T-cell receptor, and a co-stimulatory domain, either CD28 or 4-1BB. And now when the cell signals, this T-cell gets really hit hard with a proliferative and kill signal, and so it really stimulates the cell to divide, kill the cell, go off, kill some more, divide some more, and it's a cascade of activation. On the far right are the third generation CARs. That's where people say, well, if more is better, let's stick 2 of these domains in there. Let's put a 28 and a 4-1BB or an OX40. And so far, these actually haven't worked any better. But we have some third generation CARs in the clinic, but thus far, it's not proof that that is a better approach. So right now, all the action has been with the second generation CARs. Most of the commercial product, well, all the commercial products in the clinic are second generation CARs. And remember that the axi-captogene Cellular is CD28, and the tisagenlecleucel is 4-1BB. And that does make a big difference in terms of the speed of onset of the proliferation of the cells and the onset of toxicity. All right, I'm going to skip this because I went through it in great detail, and now you're all experts. You guys all wrote that down. And but the point I want to cue you in on, this is unlike any other kind of chemotherapy, of course, in that it's a living drug. And when you give these cells, so these black bars, the height of these black bars are the percentage of T cells in the patient's blood that are actually CAR T cells. We can measure them by a marker, and you can see that early on there's almost none of them left, like 0.1%. They're just not detected. They kind of blip up, then they go down. But between days 3 and 7, you can see suddenly there's a huge proliferation of the CAR T cells, and by day 10 in this patient, you can see there's now about 50 to 80% of the cells are CAR T cells. So shown in the bottom of that curve, or the bottom of that slide, are the flow dot diagrams using a marker for another molecule we put into the CAR T cells so we can follow them with flow cytometry. And you can see at day 7 and day 10 in there, I'll try to point over here, but you can see this box has a high percentage of cells. These are now pure CAR T cells that are expressing the receptor in the patient's system, and they rapidly explode. There are estimates that these cells can divide every 8 to 12 hours. So if you think about that, in 2 days, you have 4 doublings. So 4 doublings is about 10-fold. So in 2 days, you got 10 times more than you had before. 2 more days, 100 times 4. 2 more days, 1,000 times 4. So these cells just exponentially can grow, and that's why it's a bit unpredictable in what's going to happen once you give these cells. So when they proliferate, then that's where we start seeing toxicity. So when they get to these high numbers and people get tumor lysis syndrome, where the tumor can go away in a heartbeat, they can get the cytokine release syndrome and neurologic toxicity and kill the tumor cells, hopefully, and then the cells can hang out and provide surveillance. Now, one of the big mysteries and questions right now is how long do they actually have to hang out to cure you? Do they really need to stick around for 10 years, or if they're around for 4 months or 6 months or 28 days, what's necessary to cure you? And we really don't know. We think it's probably some kind of an area under the curve, but we honestly don't yet know that data. Okay, so this was one of our first patients treated, 24-year-old with Ph-positive ALL. In fact, this was the patient I think we were talking about with Lindsay before. She had no white cells left at all, and the only ones she had were blasts. She had a bone marrow with 98% ALL in the bone marrow and had failed every chemotherapy and TKIs and was quite sick. We couldn't even find an interface when they were running it on the apheresis, and I told Lindsay just take your best guess and we'll see whether we get enough T cells. And we were able to make a product and treat her. And we gave her this huge dose of 2 × 10⁵. This is a really tiny dose. If you spin that down on a test tube, it's a little dot in the bottom of the tube. And of course, we give that in a bag of saline, but there's really mostly saline. And it goes in and nothing happened. Absolutely nothing happened, no symptoms. We kept her in the hospital overnight, let her go out, and then monitored her in the clinic for the next week, and absolutely nothing happened. And then you can see right around day 9, suddenly she spiked a fever to almost 40 degrees and got admitted to the hospital and then got quite ill. Temperature goes up to over 41, you can see, by day 10 or 11. And at which point, and we had a policy of don't do anything because we were afraid of blocking the T cells from attacking the cancer, so we didn't do anything. So she ended up in the ICU on 2 pressors, norepinephrine and vasopressin, and then we started getting nervous that she was really sick, and ended up at that point saying, okay, we give up. We're going to calm things down a little bit. Gave her tocilizumab and some steroids, and you can see right after the toci, hours of the toci, she goes from 41 degrees basically to hypothermic around 36 degrees. So remarkable response. When you see this happen, you just go, wow, this person was really, really sick, and then immediately things quite change around. But you can also measure these other things. If ferritin goes very high, LDH went up. She went into tumor lysis syndrome. LDH went over 10,000. And so she really was having significant toxicity. And if you measure in the blood, you can measure TNF alpha, IL-6, interferon gamma. These are the cytokines we associate now with tumor lysis syndrome. And the amazing thing was that her bone marrow, which was 98% at the beginning, on 21 days was an MRD negative complete remission. Just astounding. And when you see this happen, I mean, literally, we were just like, are you kidding me? That really happened in 3 weeks? And this is in somebody who had a life expectancy of literally a week or 2, right? I mean, when you see this happen, it's remarkable. So we know we're on to something, and that's what got everyone really excited about this. And Tisagen laclusil then was approved for the pediatric young adult population. We don't have an approved drug yet in the adults for ALL, but obviously this is an area of much interest. Okay, now, just with that background, I want to just give you a little bit of data, a snapshot of data from our protocol 2639. This was a huge clinical trial. It actually enrolled about 208 patients so far. We have 2 patients left to be treated on this trial. They're both on the service right now, and they have CLL. So this will actually be closing this clinical trial finally, and I'm glad to be almost completed with it. This is we use a combined mixture of, we combine a mixture of both CD4 and CD8 cells. As I was mentioning earlier, we think this gives us a better dose response and dose toxicity relationship. And this was really a phase 1/2 trial. There was no criteria on what lymphocyte count you had. They didn't have to have a test expansion. Didn't matter whether you had 100,000 circulating lymphoma cells, and it didn't matter whether you'd failed in a cord blood, haplo, match-related, match-unrelated transplant. Doesn't matter. We were able to treat pretty much anybody in this with a variety of diseases. And I'm really we've published 5 papers on this already, looking at toxicity and neurologic toxicity as well as outcome in CLL lymphoma and leukemia. And I'm just gonna focus on the lymphoma and kind of say some of the things we learned. And I'll show you that. So I mentioned earlier that Cytoxan and fludarabine was important. Well, why is it important? Well, if you don't give it, you generally don't get a very good proliferation of the T cells. Shown on this curve to the right is the peak level of CAR T cells by logarithmic expansion. And you can see that the red dots are after patients got Cy/Flu, the black dots are without the fludarabine. In general, the red dots are to the right of the black dots. So there seems to be an association between giving Cy/Flu and getting a better expansion. And in fact, when we looked at those people that had those black dots, even if around 80% of those people had a remission, they all relapsed. And the reason they all relapsed is they actually rejected their CAR T cells. Now this is a bit hard to figure out, but their normal T cells recognized the peptide from the antibody that was in the CAR and killed the CAR T cells. So the patient's immune system's normal T cells train themselves to kill the CAR T cells. And so this is a real problem in the field. And one of the ways around that is to give better lymphodepleting chemotherapy, and that's what the fludarabine actually does. So there's 2 reasons to give it. It's better lymphodepletion, but it also prevents this immune response, and it allows for better persistence of the cells. So if you actually measure the patient's serum, I remember I told you that the endogenous homeostatic cytokines cause the T cells to proliferate. You can actually measure higher IL-7 and 15 just after the Cy/Flu compared to just after Cy. And then this leads into longer persistence of the CAR T cells, and that leads to better outcome. So here the red curves are above the black curves. So this became very critical for the field, and virtually all of the commercial CAR T cells recommend using a Cy/Flu lymphodepletion because it provides better persistence and expansion. And if you just look at the expansion of the CAR T cells, be it CD4 or CD8, again, these are at the same dose of T cells. You can see the red lines are much above the black lines. And if you give fludarabine, you can actually give a second infusion after another go-round of Cy/Flu in some patients and get expansion, whereas if you do that after Cy alone, then nobody basically responds. So better responses, better persistence, and this then translates into better clinical outcome. This is an example of a patient with a blastic pleomorphic mantle cell lymphoma, and this patient had failed an allogeneic stem cell transplant a year or 2 previously, had this huge mass shown in the bright colors there above his left kidney, and went into complete remission on day 28 after CAR T cells, and that was around 4 years ago. So, you see this happen, and you realize, this can be quite, this is different than you would expect from conventional chemotherapy. It's a living drug. It may persist for some period of time, and that can be both good and bad. Because what's one of the main toxicities of CAR T cells on normal cells? I'm going to make this question and answer. Who's going to tell me? Come on, somebody yell it out here. Did somebody going to say B cells? Your normal B cells. Yeah, your normal B cells get knocked off by the CAR T cells, and what do B cells make? Well, they make plasma cells. That makes antibodies, and so patients become immunoglobulin deficient if they have persistent CAR T cells around, and so they may need to get IVIG if they have persistent CAR T cells knocking off their normal B cells for a period of time. So that's an expected on-target toxicity of a CD19 or a CD20 directed CAR T cell. Okay, so we actually went back to look at some of the patients treated in this trial and just presented this a week ago at ASCO, as a matter of fact. We looked at the patients who had lymphoma, that's that group in the middle, who then got our targeted dose of dose level 2 and Cytoxan and fludarabine. There were 57 patients in that study. And we looked at the response rates in this patient population with the idea of looking at the durable remissions. How many people stayed in remissions? Can we figure out any of the factors that made this work better? And we looked at aggressive, indolent, or all patients. You can see about 60% of patients had a remission and overall, but the indolent patients, around 90% of patients actually have a remission. And this translates, if you get a CR, into pretty good outcome. So what we're showing is that if you can get a complete remission, then your risk of relapse after a year or so is pretty low. And that's why there's a lot of excitement about this technology, that it could potentially be curative. But I have to tell you, 2 years of follow-up is not 10 years of follow-up. And so there's lots of things that can still happen in these situations, and we need really to follow. But this is in a population where the expected survival is literally less than 6 months. And so it's probably better than that kind of an option. Now, some of the things we've been learning is that if patients have a very high serum LDH, they don't do as well. So this is a measure of inflammation and a measure of T cell proliferation. And if they have a very high LDH, then the T cells don't seem to proliferate as well or can't catch up. And in that upper left corner is the proliferation of the T cells in patients who have a remission versus not. And you can see the ones that have a remission, the T cells really proliferate. So this is kind of a bit of a catch-22. For this to work, the T cells have to grow, and the T cells have to proliferate. But what is that associated with? Well, I'll show you in a minute. That's also associated with increasing toxicity. So this is a balancing act between having your T cells proliferate versus having not enough proliferation and playing off the toxicity. So we talked about this already, cytokine release syndrome and neurologic toxicity. So what can we say are some of the factors that are in there? Well, first of all, just if you get the dose right, and so if you use Cy/Flu and you dial the dose up and down, turns out 2 times 10 to the 5th was too little. So this is a Goldilocks phenomenon. 2 times 10 to the 7th was too high. We actually had patient deaths at that level. And so 2 by 10 to the 6 cells per kilo is the sweet spot. And you can see that the severe CRS, as least by ICU admission, was only 1 in 11, 9%, and about 18% had neurologic toxicity. But if you went up to 100 or 10-fold higher, 50% of the patients were in the ICU, and almost 2/3 had neurologic toxicity. So no matter what people say, dose matters. Okay, so if you have a defined product, CD4 and CD8 cells, where everyone's getting exactly the same thing, as opposed to getting a completely wild, varied range of CD4s and CD8s, you can actually dial in a dose and get an acceptable dose response and dose toxicity. Now, the kinetics of this cytokine release syndrome are shown in these curves. This is from a blood publication on CRS. Patients who get into really trouble have the onset of CRS really quick. So if you have a fever within 6 or 12 hours of CAR T cell infusion, and it's going up to 39 or 40, then that's a group you got to better watch out for, and you better intervene early. Whereas you can see that patients who had grade 1 to 3 CRS, it started meeting around 4 days and much less toxicity. You can also then just look at the temperature shown on that upper right curve, and you can see the people that had grade 4 or 5 CRS were the people that had literally 40-degree temperatures within the first 48 hours. So if you see that, at least with this 41BB CAR, then that's something you need to be more nervous about. Okay, the other thing in the bottom left is that cytokine release syndrome and neurologic toxicity are usually related, but the neurologic toxicity occurs a bit later. So you can see that the grade of neurologic toxicity is associated with the grade of CRS in general. So the high-grade CRS can lead to a higher grade neurologic toxicity, but it's not one-to-one. And there are patients who just get neurologic toxicity without any CRS, which can certainly happen, and there are people that get CRS and never have a whiff of neurologic toxicity, even significant CRS. So in the bottom right curve there, you can see the onset of fever versus the onset of neurologic toxicity. And typically, as I mentioned earlier, the neurologic toxicity lags behind the CRS by a few days. So you may think you're out of the woods, everything's really, really fine, and you can get into trouble with your patient now presenting with severe neurologic toxicity despite the CRS being completely gone. Now, the other issue, as I mentioned before, is that the proliferation of the T cells in the blood is correlated with toxicity. So you can see now here the height of these curves is the log amount of CAR T cells in the blood, and you can see the people that had severe through grade 4 or 5 CRS had the highest proliferation of the CAR T cells. So lots of CAR T cells means there's the potential for more toxicity. So then if you actually try to put together a probability curve, this gets a little bit confusing, but try to focus on these curves. Shown in this upper part up here, that's the probability essentially of getting neurologic toxicity or getting CRS. Okay, so what does that mean? As the T cells proliferate, that's this direction, the probability of getting CRS or neurotox goes up. So, and you don't see, there's no free lunch in here, right? The more the T cells proliferate, the more potential toxicity you get. Now, shown in this lower part of the curve is your probability of getting a complete remission or getting a response. And you can see with ALL, it's actually pretty fast. And so you don't need to have a huge proliferation of CAR T cells to get a CR with ALL, but with lymphoma, your probability of a CR increases with the expansion of the T cells. And so if you really want to drive a CR, you need to drive the proliferation, but that also then drives the toxicity. Okay, so we're walking a fine line here, trying to figure out how to treat patients with the most optimal amount of CAR T cells to hopefully guarantee the cells proliferate, but not so high that you end up with toxicity. So it's a challenge for obviously everyone involved. So one of the things we can do now by looking at those factors early on, you can get an idea of who's going to do the worst or at the risk of the highest degree of toxicity. And by using like temperature within the first 36 hours and then adding an MCP, you can actually get to the point where you're now you're narrowing down to people that have about a 50-50 chance of getting severe toxicity, and you would maybe be able to then intervene early in that population before they get sick. And that'll be the next generation of trials using algorithms such as this. But even if you just use temperature, you can see that it's pretty good. Just by looking at a temperature early, you make it down to now 1 in 3 risk of getting severe toxicity. So there's lots of tricks we can do as we get more data. Okay, the management of CRS is very complicated and it's product specific, but in general, just the things to remember, grade 1 is really just symptoms only. Grade 2 is more serious. You need oxygen, less than 40%, and you have hypotension and you're having to give them boluses of fluid, so that's really a 2. If you're beyond that, if you're on pressors or you're getting more oxygen, then that's generally grade 3, and if you're intubated or on dialysis, then that's generally grade 4. So now, in most cases, we're intervening in grade 2 CRS to try to prevent that from becoming grade 3, and using those measures I talked about before, tocilizumab and steroids. But this is a big, complicated issue. It's also complicated by the fact that the companies don't agree on the 2 different products. And this is really confusing in the clinic. Just imagine you're in the middle of the night, you get called up and say, okay, your patient is, having grade 2 CRS, and one of the products says treat and one says watch, and you're trying to figure out, well, what did they get? Who got what? So I think we need to unify our approach to cytokine release syndrome, and there's a lot of effort underfoot to try to come up with unifying both diagnoses, grading scales, which are better than the Lee criteria, and things that can uniformly manage these patients so that we don't get into these issues of having multiple CARs in the clinic and confusion. But each REMS program is a little bit different, and even the REMS programs aren't exactly what the companies really want you to do. So that's even more confusing when you need to talk about that. All right, so my observations from our Hutch trials just in lymphoma, that this has potent anti-tumor activity. The defined composition, I didn't really show you a lot of data, but we think it's better than the commercial products out there in terms of its dose response and dose toxicity. And that was then led to the Geno cell gene products, which I'll show you the data on. Immunogenicity is a problem, and patients can reject their CAR T cells. Why is that important? Well, if you reject one, that means you'll reject all of them, because they all use the same murine single-chain Fv. So if you make an immune response against ours, you're not going to respond to Yescarta or Kymriah. Likewise, if you make an immune response to one of those, you're not going to respond to one of the other ones. So immunogenicity is going to be important. We think that may be a limiting factor in some patients, but not all patients. And the Cy/Flu makes us better. And neurologic toxicity correlates with the expansion. So it's a problem to disassociate what you want from the toxicity. Okay, we're going to talk about commercial CARs now, and I'll just say a few words about them and then kind of wrap back up and then hopefully take a bunch of questions. So the first one I'm going to talk about is axicabtagene ciloleucel, Tcell or Yescarta, and this is the first CAR approved in the lymphoma field. It's a different product than what I've been talking about so far that we use at the Hutch. It's the same single chain Fv, but it's connected to a T-cell receptor with a CD28 domain. And CD28, if you just had to think about what it does in biology, it's a little hotter and it causes a more rapid proliferation of the CAR T cells. And that's what we see in the clinic. People get sicker quicker, and that's why it's usually done as an inpatient. Well, in fact, it's only been done as an inpatient. Now, the trial that they did was against a historical comparison called the Scholar-1. And in the Scholar-1 shown in the bottom portion of that slide, they took a bunch of patients with relapsed large cell lymphoma with 2 prior regimens, and their chance of getting into any kind of a remission with anything was only 26%. And only 8% of those people had a complete remission, and 18% had a PR, and their survival was only 6 months. So that's the benchmark that they were trying to go into to say, can we come up with something that's better than that? So the long-term survival is incredibly rare in twice relapsed large cell lymphoma patients. Again, most of these people had failed transplants or were not eligible for a transplant. So I'm not going to really belabor this, but this is the characteristics they treated: large cell lymphoma, primary mediastinal B-cell lymphoma, and transformed follicular lymphoma patients. 101 in the pivotal trial. There was another 7 patients in the ramp up to this. And you can see that they're pretty heavily treated, but only around 20% had a prior transplant. So that's a little bit different population. The other thing I'll make a note of this is that they did not allow intervening chemotherapy between leukapheresis or apheresis and treatment. And so the patients had to make it that far without getting any therapy. And they were pretty quick on it, and they were able to do it in around 17 days back to the patient, which is pretty darn fast. So patients could actually be able to do that. But it's really complicated to look at these trials and figure out what that means in terms of comparing between one to the other. It won't stop me from trying, but so as you saw, I'm going to try. I'll still try to do it anyway, even though it's probably not valid. So this was the results of the trial. Very good. The response rate combined was 82% overall response rate, and 54% of these patients actually had a complete remission, which is outstanding. And these are the curves from the subsequent New England Journal of paper that came out. And I just want to point out that curve, the top curve. This is an outstanding result. So unfortunately, that's only the people that had complete remission. But if you have a complete remission, your chances of relapsing out here seem to be pretty good. And that's why, again, everyone is really excited that this could be a potentially curative treatment. Most of the time when you see curves, they're always continuously dropping off as people relapse. And so the problem is, if you didn't have a good response, or if you had actually only a partial remission, you can see their survival was really poor, just like you'd expect from this population where people live a matter of months at best because there's really no other options to keep them alive. So this was really a tremendous outcome, really a major breakthrough in the treatment of patients with relapsed refractory lymphoma. And it serves as really the benchmark that everyone needs to beat. But again, I just remind you, this is of the people that had a complete remission. It's not of all patients. So then when you look at the entire I guess I didn't put that in there, but if you look at the entire population, that's around 40% survival of the overall group. Axicabtagene was Yescarta was FDA approved, again, for these specific types of lymphoma after 2 prior regimens, and I went through that eligibility before. but I'll also point out that there's a REMS training program that's required, and it's a bit, it's a lot of work, let's just put it that way, and a lot of people need to be trained. And there's black box warning for 3 different effects here: cytokine release syndrome, neurologic toxicities, and then also there's a mention of the fact that patients can have prolonged cytopenias. And I think that's in part related to the chemotherapy, which is a little higher dose of cyclophosphamide than we're using in our study, Cy/Flu, but it's the same combination. So patients can have persistent cytopenias that last for months after this treatment, and it's something you have to be aware of. All right, so that was the first approval. That was last summer. And the second one was approved just earlier last month in early May. So this is tisagenlecleucel, which was previously approved, the first CAR approved for childhood, pediatric, young adult ALL, but now it's also been approved for lymphoma. And it is a different CAR. It uses the same single-chain FV, but it actually uses a 4-1BB, a co-stimulatory domain, like the product we were using in Seattle. Again, it enhances the proliferation and persistence of the CAR T cells, and otherwise it's a quite similar CAR. It's again against CD19, and it has the same murine single-chain FV that all 3 of the products have. So this was their study that they had presented at ASH. This has been slightly updated in the product insert, but the paper has not yet been published, so I don't have as many details about the actual clinical trial. But they, as you can see, they treated about 100 patients. These patients were a little more treated than in the other trial, and 50% or so had prior auto transplant. And bridging chemotherapy was required in almost 90% of these patients. 89 out of 99 had to get bridging chemotherapy to stay alive while they were trying to make the CAR T cells. So again, a big difference between the KITE trial, where people couldn't receive it and they very quickly went from apheresis to treatment. In this study, patients had their cells collected, and then there were limited slots available, and then they had to do something to try to keep people alive until they could be treated. But this also resulted in about 1/3 of the patients, or maybe 1/4 of the patients, not being able to get their CAR T cell infusion because they died or progressed before they could even get treated, which is just a characteristic of the study design, not anything different about the product. Right, so the response rates with this also are quite good: 53% overall response rate, 40% CR, and then at 3 months, it drops down to about 30%. And this looks very good. Again, this is the duration of response. So if you don't have a response, you can't have a duration of the response. So you have to remember that only 50% of people had a response. So this is 74% of 50%. So if you do that math, you're down around 36% or so of the patients are doing well. But again, it's very impressive. And is this different than the other product? Not sure, but it's also encouraging. And this led to the FDA approval of this. And again, very encouraging that the shape of this curve seems to be somewhat flat. Everyone's really waiting for this paper to be published, hopefully in the next weeks to months. So the summary from this study, tisagenlecleucel, is a response rate around 50%, CR rate of 40%, and 30% of those were durable. And the ones that are durable at 3 months seem to be durable at 6 months. This was updated a little bit at EHA, and it seems to be holding. The most common adverse event was CRS, and they had 58% having any grade CRS, and 23% experiencing grade 3 or 4. Now, that's quite a bit lower in the overall CRS than the KITE product, but it's using a different scale as well, so this is really difficult to compare. The grade 3-4 neurologic toxicity was less, only around 12%, but the patients were managed later on in this trial better than early on. Early on, patients were really allowed to get quite sick before they were intervened, and later in the trial, patients received earlier toci or steroids. So it really makes it almost impossible to compare these trials as they are sequentially being done. But the other key thing here is because this is a 4-1BB CAR, there's more experience with doing it as an outpatient. And this is similar to our study where about now, probably 90% of our patients are treated as an outpatient, not requiring any inpatient hospitalization for the treatment. And then about 70% of people do require hospitalization at some point for CRS. Okay, now I can't use commercial CARs anymore because lisocabtagene maraleucel or Lysosol isn't approved yet, so this is pre-commercial CAR, but it's based on our work in Seattle, and it's been now work with Geno therapeutics, which is now Geno Celgene, and this is again using our Seattle technology where we split the cells into CD4 and CD8 cells, make 2 CARs, give them back at a 1-to-1 ratio, again with that idea of refining toxicity and maximizing tumor effect, but also minimizing toxicity. And so this study was just presented by Jeremy Abramson at ASCO last week. So this was the Transcend trial, and this is just showing the kind of flow of the study. Patients have an apheresis. It takes about 3 to 4 weeks to make the cells. They receive lymphodepletion with flu/cy, and then they get their infusion and then are followed. There's been several cohorts of patients enrolled in this study, and they're shown down here. And really, there's a full population, and then there's a core population. And the core population differs from the full population in that it's restricted to make it more like the population that was enrolled actually in the Juliet trial, the Novartis trial, and the Kite trial. So it's the same populations. It restricted it to ECOG of 1 or less. Previously, we enrolled a lot of ECOG 2s. It also restricted the histologies to make it similar to the other studies. It does allow prior transplant, auto transplant, but not allo transplant in the core population. And actually, the one key difference is all the other studies excluded CNS involvement. This study actually allowed patient to have, including meningeal leukemia or lymphoma, but also parenchymal masses. And there's a paper published on a case report of someone actually having a large mass go away from CAR T cells in the brain. And so that's remarkable that the cells can get in there. So there are some differences between the studies. So this is the consort diagram of the patients treated in this portion of the study. You can see that 114 patients were treated. And if you then look at trying to look at this is a dose finding study, and dose level 2 was selected as the dose to go forward. And I can show you some of that data. Product was made in 99% of the patients. There were a few mantle cell patients in the overall cohort. And we've treated about 8 patients in this study as an outpatient as we were getting up to speed. So this is the characteristics of the full and the core population. Most of these patients had very high-risk disease. 90% had high-risk features. And I'm not going to really belabor it, but you can see these characteristics are all pretty bad, either having failed a transplant or not even being able to get to a transplant. So what are the side effects? Well, these are the side effect profile with this CAR, and you can kind of look at these top ones here that go through thrombocytopenia and anemia. On all of those toxicities are expected from the chemotherapy. That's from the Cy/Flu. If you get down to where the effects of the CAR T cells are, you can see this curve right here is cytokine release syndrome. And any degree of cytokine release syndrome was only seen in about 37% of the patients. And grade 3 or 4, there was only 1 grade 3 CRS. So this seems different than what I've shown you in the other products. So only about a third of people had any CRS, and only 1 in 100 actually had grade 3 CRS. So that makes it a little more easier to potentially do this, in the outpatient setting. And you can see a variety of other constitutional symptoms. Headache is probably real. I mean, you see headache down here. That's probably neurologic toxicity from CAR T cells, although it also can be from Zofran, as you know. But so it gets lumped into neurologic toxicities for these studies. All right, so if you then look at patients who now receive the maximal dose, the dose that's selected to go forward, you can see there's no increase in the toxicity, significant increase in toxicity between dose level 1 and dose level 2. And you can see that the result, the risk of Any grade CRS is really pretty low, and severe is quite low. And the same thing, neurologic toxicity is higher. It's around overall 13% of the population, grade 3, 4, and 23% any grade. So this translates into relatively low risk of having to intervene. So only 17% receive Toci and 21% receive steroids. So again, correlate that with about 50% or 47% in oxycaptogene, Cellular, or Yescarta. So you get this sense anyway that toxicity might be a little bit less. Obviously, we don't have the pivotal population yet. But what about the response rates? Well, if you look at the overall response rates in the entire population, or if you subset it down into the cohorts, you can see the overall response rate is about 75%, CR rate around 55 to 60%, and this translates into about a 50% 3 and 6 month CR rate in this population, and this looks pretty encouraging. So here's the progression-free survival curves of the CR patients. Obviously, the PR patients do badly, and then if you narrow it down to the core population, it's basically the same. So is this any better? I can't say that it's any better, but it's probably equally, certainly as good in terms of its response rates, maybe that we've seen, again, in non-comparative populations. This also then translates into excellent survival for those patients who, especially if they have a complete remission. So very exciting. This will be the third CAR probably, hopefully approved by the FDA. It'll be going to the FDA on the pivotal population, which is fully enrolled, and and hopefully the FDA will be able to act on it shortly after, within 6 months of their submission. So this is a summary for this drug, lisocabtagene maraleucel, Lysocell, it's a defined composition that's different than the other products, which are just whatever T cells you can get. It has durable response rates in poor prognosis patients, great, good response rates there, and encouraging across all dose levels, and some seemingly low rates of toxicity in that population. So again, this is my landscape slide that I showed you before, which I hesitate to do because you can't really do this because they're not the same patient populations exactly. But you can see if you compare response rates and CR rates that they seem to be in the same general area. If you look at grade CRS, it seems to favor the lisocabtagene. It's clearly the 4-1BBs seem a little less than the CD28 CARs. And so these are going to give us choices in the clinic. So what are the challenges with doing this? Well, the first one is insurance clearance, and this is partly because there are high costs of the drug. So oxycaptogene and Kymriah, now both for lymphoma, are now $373,000, and that's just for the parts. That's not the service. You guys know the service costs a lot too. And so the total cost of the drug and the therapy is much more than the actual cost of the drug. We don't know, obviously, if Lysocell gets approved, what that will cost. Actually, interestingly, Kymriah for pediatric ALL is still priced at $475,000, and I was a bit surprised by that because I didn't figure you could charge the exact same thing for the drug to two different populations, and just because you're treating kids, I mean, you can't charge more, right? So, but there's a way around this, and the reason is that you get a money-back guarantee in this situation. If you don't go into complete remission by 28 to 45 days, you actually don't have to pay the $475,000. Now, you still have to pay the service, right, because whatever that's going to be. But so there's about 15% of pediatric young adult ALLs who don't go into remission. So if you add that all up or subtract that all out, it comes out around $373,000. So that's their justification, I think, for continuing that. But again, I don't work for Novartis. Now, the other problem is the manufacturers get off pretty good here because the center pays all the money independent of what they get paid back. So if I get $10 back for CAR T cells, I still have to pay Kite or Novartis $373,000. So it's a pretty bad deal for the center, okay? And so there are many centers that are looking at us and saying, no, thank you, not going to do this because you're taking all the risk, and the companies are not taking any risk in this other than whether they can make the product. And so we think something has to change in the future, and nobody is giving money-back guarantees in lymphoma, whereas I showed you the response rates are closer to 50%. And no one's going to, at least so far, not doing that. But this needs to be fixed too, and going forward. The other thing is that payers don't have any policies in place to actually figure out how to pay this. We have to negotiate with every different company, every different payer. Even if they actually say it's medically necessary, that doesn't mean they'll actually pay for it, right? Or they won't agree to your terms to pay for it. So this has been a real challenge, and there's going to be some other discussions coming up, I think, in either today or tomorrow, looking at some of these financial implications. And we really need to get together, I think, and get on the same page. And then lastly, Medicare and Medicaid really don't have the policies in place, or they're just developing them, and that still can stick the patient with only 20% of the bill. But 20% of $475,000 is still a lot of money, and most people don't have that kind of money left around to be able to pay for this therapy without secondary insurance. And to the company's credit, there are a lot of patient assistance things that are being done, assistance with housing, assistance with cost of drug, and I think these are important to go forward. But it makes it really complicated to do this in a center. So how are we going to choose in the clinic? And probably everyone's heard me say this about 50 times, but the major determinants are going to be efficacy. So if one of the products cures a substantial more patients, then that's going to get a nod. Obviously, the complete remission rate eventually, that's going to be really, really important. But equally important is going to be safety. If one of these products is very safe in terms of CRS and neurotoxicity, and the efficacy is the same, then I think it's going to get the nod. Centers are going to vote with their, with how many people they have to have in the hospital, how many people have to be in the ICU, and whether you can do this inpatient or outpatient. This is going to be a key factor going forward. And then lastly, cost probably has something to do with it, although probably not as much as the first two. So cost is very likely going to be dependent on how well it works and what the safety profile is. And so it'll be interesting to see what happens. And then obviously, is there going to be value-based pricing in lymphoma? Probably not, but maybe some kind of thing in the future. So again, high response rates in leukemia, 2 FDA-approved drugs. For this to work better, it needs to be worldwide, it needs to be reliable, it needs to be quick, it needs to be rapid turnaround. It's going to still need to be done in specialized centers, and cost reimbursement needs to be worked out. So just a couple of slides. What about other targets? We have CD19 CARs for ALL, adult ALL, and this resulted in a high MRD negative complete remission rate. We have trials in CLL. We have an anti-CD20 CAR in lymphoma. We have several BCMA trials given to try to make this work better, and this is tremendously exciting. I think you heard some data about that before. I have a trial in ROR1 in lung cancer and breast cancer, which is quite exciting. We're getting off the ground. And then there's combinations. We can do all kinds of things, adding this. In one case, it's a humanized CAR, which doesn't have the mouse part, so hopefully it won't be rejected. And you can do combinations with checkpoint inhibitor antibodies, and there are multiple clinical trials going on like that. Well, what about T-cell-based therapies? Well, there's trials in WT1, this is expressed in leukemia, and HA1, this is expressed also in leukemia, and these are exciting trials that we're learning about. So this is a slide I borrowed from Jeff, looking at our current active trials in the clinic. There's about 12 of them now that we've wrapped up with 2639, and you can see there's a wide variety of diseases. And I think there's about 20 trials on the block to try to get implemented right now. But this is obviously a challenge in the clinic to keep track of 12 different trials, different research groups, coordinators, to be able to do this. And that's why having a unified center really makes this important. So again, what are the challenges? That's patient-specific therapy. The characteristics likely affect the ability to generate the cells. The current products are very effective, but they're each different. You can't just say CAR T-cell and mean the same thing. You have to talk about which product are you talking about, which disease are you talking about. And the cells are different. They've grown from different technologies. They're grown from different mixtures of T-cell subsets, and they may be given at different doses. The REMS program and toxicity management is not the same. Your center has to be on board with what it is for each of these different drugs, and it requires, obviously, expertise in specialized centers, and it should, I think, stay in specialized centers until we have a better idea of the challenges. So this is the Bezos Family Immunotherapy Clinic. I think I've told this story before. My first patient was there and said, looks around and says, wow, this is so bright. It's just like an Apple store. And so it is kind of like the Apple store for CAR T-cell therapy. And I invite you to visit. And again, thanks to my colleagues. Thanks very much. I think we have 6 minutes for questions if anyone has any questions. Fire away. I know you've been getting for a chance to get at me.
I actually have 2 questions,
Yeah.
quick questions. First, you said that it's unknown how long these cells will remain in the system. Is it possible that these cells will be reactivated at some point when the disease comes back? Because we had the trial over Montefiore. We are in the BMT team in New York. And we had a patient who had, on the physical exam, had possible relapse, and the PET-CT also showed it, and 6 weeks later, it all disappeared.
Yeah.
So we don't know what happened.
Yeah, well, let me answer that one first. So we think that's a really good question, and we don't know the answer. There have been some strange cases where people have had their CAR T cells seem to disappear. They popped up with a lymph node. They actually biopsied that lymph node, and by biopsying it with a needle, the CAR T cells reactivated and put them into complete remission. In that case, including a brain lesion, which was really astounding. So there is a lot of things we don't know. In most cases, CAR T cells tend to go away with time, and they're hard to detect after 6 to 12 months. You can detect them sometimes by PCR assays, but that's not really the right thing to do. What you really want to do, if you want to look for CAR T cells, is look for normal B cells. Okay? If you have normal B cells that express CD19, you don't have functional CAR T cells, no matter what the PCR test does. You don't need a sophisticated test. Just do a regular flow cytometry for B cells. If you have normal B cells, then you don't have T cells. Now, if you lose those CAR T cells early and you have normal B cells come back, your risk of relapse goes way up, especially if that's in the short period. Okay? Now, interestingly, if your B cells stay depleted and you relapse a year later, then you're likely still have good T cells, but what happened? The tumor lost the target. So now you have CD19 negative tumor. And this has been seen in the pediatric young adult ALL and in the adult ALL, and to a lesser degree in lymphoma, but it was also seen in the Zuma-1 trial, whereas about 2/3 of the patients that eventually relapsed could have no CD19. So that's a limitation. So how are we going to get around that? Well, we need to give 2 CARs, right? You never treat a really serious infection with 1 antibiotic. You're going to give a second one. It's the same thing. You're probably going to have to give 2 CARs against another target. Sorry, long answer, but really good question.
Thank you so much. And the second one is, what's your experience with a second infusion? Have you ever given
Yeah,
a second
so I
infusion?
showed you a little bit of that data. It generally doesn't work. We've had it work a few times, but in patients, certainly, that if they made an immune response and lost their CAR T cells, then it doesn't work. If they haven't made an immune response, then it sometimes works. So I would say right now the track record is around 20% for retreatment. And so it's kind of, the jury's out still. That's a good question. All right, who else?
Is there any way where you see the signs where we're going to start doing CAR T up front and working our way backward?
Yeah, great question. What's the future? Well, we already know some of the future. So with these 3 CARs I just showed you, commercial or almost commercial, I can't jump the gun there. All three of those platforms are being used in a randomized study against auto transplant in first relapse large cell. So this was all in second or third relapse, right? So now you can move it up potentially to first relapse. So imagine somebody who's primary refractory or first relapse, get it randomized immediately straight to CAR or to an auto transplant. Okay, so my guess is that's going to win. I think the CARs, I don't know how they can lose really in that setting because auto transplant doesn't work very well. I mean, I'm a transplanter too, but frankly, if you relapse early after R-CHOP, your chances of getting a CR and cured with a transplant are less than 20%. So CARs are going to beat that, and so I can envision that after the next go round, we're going to get rid of auto transplant and first relapse large cell, and then we'll see from there. Now, could you even move it up front? Yeah, I don't know. I mean, R-CHOP does pretty well in curing people with aggressive lymphoma. So the question is, could you find a group that is so risky where R-CHOP probably wouldn't go? And then you could potentially do a trial where you probably can't do it immediately, but maybe you gave a few cycles of treatment and then randomized to either continuing therapy or getting a CAR. So yeah, I think that'll be the future. Yeah, but we need to make it work in other diseases. We need to make it work in breast cancer, lung cancer, and some of these other diseases. All right, any more? I think I have 1 minute and 13 seconds. So. No? I'm going to give it back to Kathleen then. Thanks, guys.